A very good evening to all of you. So, WINCARS is back again, yet with another academic initiative of its. We know that WINCARS has always pestered for women health, especially when it comes to cardiovascular diseases, and especially under the aegis of our patron and our advisor, Dr. Jyotsna Madury, who has recently got the Legend Award. Thank you, ma'am, for joining us today as the examiner. And we also have one of a very dynamic ladies who's leading cardiology in forefront in India, Dr. Vijayalakshmi, ma'am. Thank you, ma'am, for joining us.
Yeah,
And
good evening.
yeah, good evening. And WINCARS, looking forward with its activity, organizes an e-class on every second Thursday of the month for the benefit of the cardiology students across the country. And we are really pleased to invite and have amidst us none other than the head of the department at AIMS Bilaspur of Cardiology, Dr. Navdeep Sidhu. Thank you so much for joining us and having your DM student with us to present a very interesting case. So, not getting between you and the academic deliberation, I call upon this Sowmya to call the DM student and start the rigid examiner processes, because the examiners today are really tough and they're going to lead across and teach us how we should proceed with when we have patients as this. Sowmya, off to you.
Good evening, everybody. Thank you, Shibba ma'am, for the wonderful introduction. Without much further ado, I call on Dr. Puneet, who is the postgraduate from All India Institute Bilaspur, to present his case. The examiners will be Dr. Navdeep and Dr. Vijayalakshmi and Dr. Jyotsna. Over to you, Dr. Puneet. Go ahead.
Respected teachers and my colleagues, good evening. I am going to present my case on congenital heart disease. My case is 25 years old female from Roopnagar, Punjab. Uh, History was given by patient herself and her mother. Patient presented with chief complaint of progressive dyspnea since 6 years of age. History of present illness: patient was apparently asymptomatic till 6 years of age. When she was when she started feeling breathless on playing with friends, and which a grade 1, which was insidious in onset, and then she was taken to a private hospital where patient's echocardiography was done, and she was advised some cardiac surgery. However, patient did not follow up. As per patient, dyspnea did not progress until now. Now the patient presented to us with recent worsening of dyspnea from NVH grade 1 to 3, that is while going to washroom, since 35 days. History of orthopnea present. History of palpitations on and off present, which were self-resolving. Negative history: no history of recurrent chest infections, syncope, no history of fever, cough, chest pain, hemoptysis, no history of recurrent sore throat, arthritis, abnormal movements, and skin rash, no history of pedal edema and abdominal distension, no history of bluish discoloration of skin and cyanotic spells. Family and personal history: patient has two elder sisters with
Now,
no
before
relevant.
you go to personal history, let us analyze the history that you have presented.
Yes,
Okay, you
ma'am.
said that the child was normal till 6 years and then the dyspnea started. And
Yes,
here,
ma'am.
it becomes difficult to tell whether it is a congenital or acquired, because
Yes, ma'am.
acquired diseases also will come at the age of 6 years. They become
Yes, ma'am.
symptomatic. But
Yes, ma'am.
when they analyzed earlier with the echocardiography and advised surgery, did they tell anything whether it is a congenital or acquired? What did they say?
Ma'am, they said some congenital type of disease, and they were
Okay,
advised for cardiac surgery.
okay.
Um, but the patient didn't follow up after.
But the patient doesn't know what exactly it is, so they
Yes,
have
ma'am.
not taken it seriously. Whatever
Yes, ma'am.
advice was given was not taken seriously, and that's why they did not go for the surgery. So
Yes, ma'am.
still we are not sure whether it is acquired or the congenital. So
Yes, ma'am.
here, from class 2 breathlessness, it has come to class 3. Almost
Ma'am,
going to bathroom means it is almost class 3 to class 4. So that
ma'am.
means it is a very serious problem. It is a
Hmm.
life threatening one, and it is a serious thing to be worried about. Okay.
Yes, ma'am.
And here your negative points are very important. You said there is no joint pain, there is no rashes, there is no
Hmm.
fever, nothing. So all these things it rule out the rheumatic fever or the acquired rheumatic valvular heart disease.
Yes, ma'am.
Okay.
So, Puneet,
Ma'am,
can you highlight a few of the conditions which
yes.
is detected at the age of the 6 years suggested cardiac surgery, but relatively asymptomatic, not asymptomatic, limited symptoms, and now
Yes, ma'am.
deterioration. Can you label a few of the conditions which can be like this? The natural history will be like this.
Ma'am, as a patient was advised cardiac surgery after doing echo, it can be, ma'am, shunt lesions like ASD, VSD, PDA.
Yeah, out of the shunt lesions is
Okay.
first
Okay.
possibility. Out of that,
And
considered as the first. Do you consider at the age of the 6 years for the ASD to advise surgery?
no, ma'am, no, only VSD, PDA, ASD.
Yeah, post
ASD,
tricuspid
how
shunts
many-
are they
हाँ जी,
come much
हाँ
earlier. Yes.
हाँ जी, post tricuspid shunts, ma'am.
and another thing is complicated ASDs, like in the Down
Complete.
syndrome associated or
Yeah.
otherwise multiple shunts. Then also they can advise. Okay, that is one is the shunt
And
patient.
one
हाँ
more thing is, if it is ostium primum ASD, they can come earlier, or
Yes,
like
ma'am.
a single atrium, or they also can present very early in life.
Very early. Yes,
Those
ma'am.
are exceptions. Okay.
हाँ जी.
That's why I said Down syndrome associated
Hmm.
with Down syndrome. All these madam highlighted is associated with them commonly. Yep.
Yes,
And
ma'am.
other than shunt lesions, what else you will consider?
Ma'am, it can be, ma'am, congenital AS as patient presented with dyspnea on exertion.
No, aortic stenosis, they don't advise surgery, no, because the annulus is so small and they don't do surgery. They will advise balloon dilatation.
Totally
So
ballooning, which
aortic
is advised
stenosis
at
is
this
not,
age.
yeah.
हाँ.
Yeah, yes, Navdeep.
Yes, sir. Please tell,
हाँ.
Dr. Navdeep.
Yes, ma'am. I was adding to your point only that it is highly unlikely that an aortic stenosis,
Yes.
which is likely to be congenital at this age, will be advised for a surgery. It is usually
Surgery.
the ballooning which is being done. Other
Correct.
point is that, ma'am, although it is very rare, but still we can have some possibility of RHD. There have been some cases of very young patients of RHD with mitral stenosis, or
Yeah.
other can be the congenital mitral stenosis.
Dr.
हाँ
Navdeep,
जी.
the youngest child with the mitral stenosis and tricuspid stenosis I've seen is 3 years old. So
Yes.
Yes,
three
ma'am.
years old child, that is the youngest that I have seen.
Yes, although very very rare, ma'am, but still we
Yes,
have a
yes, yes,
possibility. We have a
yes.
possibility.
हाँ.
Okay. Other than the rheumatic, any other valvular diseases other than these AS and about Madam and Sir is mentioning about rheumatic. Can you have a mitral stenosis or anything in a congenital
Congenital
Pulmonary
mitral
stenosis.
stenosis.
Sorry?
Yeah, pulmonary stenosis also
Also.
possible. They can present much later. Okay.
No, I meant it mitral stenosis. Presentation mitral stenosis
Puneet,
requiring
madam is asking about the
congenital mitral
congenital
stenosis
abnormalities of
requiring a
mitral
surgery.
valve, which can lead to mitral stenosis.
Ma'am, cotritum.
Okay. Other than that, any syndromes?
Ma'am,
What is Shone's complex?
Shone's complex, ma'am. Ma'am, it is obstruction in the left heart, basically.
Now, what are the components of Shone's complex? You tell us.
Ma'am, firstly, the obstruction is in the left atrium.
That is the supramitral ring.
Supramitral
Okay.
obstruction,
Then
and then, ma'am, mitral stenosis. Then
that is the parachute mitral.
parachute mitral stenosis. Then, ma'am, subvalvular aortic stenosis, ma'am.
Subvalvular, supravalvular, both.
Both.
Supra also it can be there. And then the coaptation.
And then, ma'am, coaptation of heart.
Yes.
Okay. So complex congenital is one possibility. Shunt lesions is another possibility. As the stenotic lesions low down in the list, that is another possibility. What do you
And
think?
rheumatic.
Rheumatic, yes.
हाँ
And
जी.
what is the reason for sudden deterioration in a 35 days from the class 1 to class 3, according to Madam class 4?
Ma'am, firstly, ma'am, there can be possibilities like ma'am, patient can precipitate with anemia, any arrhythmias, and ma'am, LV dysfunction, and development of ma'am, MR, mitral regurgitation.
Yeah, you are listing the causes, but you have some clues in your history. You said the history of the palpitation, but you know,
हाँ जी मैम
highlighted
arrhythmias.
what is the type of the palpitation? Is a regurgitant lesion type of the palpitations or the arrhythmic, and that elaborative description will give a indication to say that what is the cause for the deterioration, which you are
See,
not.
what madam is trying to tell you,
हाँ जी
understand. If it
हाँ
comes
जी
abruptly and terminates on its own, it is like a SVT. And
हाँ
if
जी
it is on exertion, then it is due to the inherent congenital heart disease or some other. So you have to tell the palpitation, describe
मैम
it properly so
I
that we
asked
can conclude. Yeah.
ma'am, I asked patient said, ma'am, these palpitations come abruptly and ma'am, within few seconds, these resolves by itself. It does not correlate with any activity like exertion.
Okay.
हाँ जी
So you think it is arrhythmic palpitation?
हाँ मैम SVT type.
Yeah.
You
So
by
yeah,
history you say
because
the
that
type
is
of
a
the
very important point. If
हाँ
it is like SVT or VT, that means it is either it is ischemic or it is a conducting system. That is the short circuiting that we are having. So like the which is the condition where this sort of tachybrady can occur. Name the
मैम
congenital heart disease.
मैम abstains normally can be
One is Epstein, then where there is a
मैम
WPW syndrome, then
WPW syndrome in abstinence normally
CTGV.
अगर CT हाँ
Yeah,
जी
in CTGV, there is an accessory, what to say, the AV node, and as a result, they can have bradycardia, tachycardia in the same patient in one day itself. So that is another thing. And what is the other thing? I had one medical student coming with palpitation, with the VT, and
मैम
that person had a ischemia for so long. That was the alkappa.
हाँ जी
So these are all
अल्कापा
rare, these are the rare conditions
हाँ
where
जी
because of ischemia they can come with the VT, and that VT can start abruptly and terminate abruptly, whereas the other conditions, no, it is random, irregularly you get the what to say, ectopics and causing the palpitation. So this palpitation indicates that there is either SVT or VT. So we have to think of CTGV, we have to think of Epstein, and we
Prince
have to think of the Alcapa. So
Spring
these are
हाँ
the
जी
possible things that we have to think of. Okay, go ahead.
ओके
just suppose you think it is a volume overload related palpitation, then what
ओके
are the conditions you wanted to consider?
Ma'am, in volume overload conditions, ma'am, these can be, ma'am, like stenotic lesions like coarctation of aorta, pulmonary stenosis.
Palpitation of the aorta. Volume, what, where you get it palpitations? One is arrhythmia, other is volume overload. And you
Volume.
are talking about a stenotic lesion. In a stenotic lesion, again, arrhythmia is responsible for it. And in the
Okay.
coarctation specifically, why there should be a palpitation specifically in that, unless it is associated with a complex congenital. And if you at least you say that mitral stenosis and producing
Mental
some
state.
atrial fibrillation has a meaning.
Okay, ma'am.
So the volume overload, either MR or AR can produce the
MR.
palpitations which are exertional usually. But in your case, it is not there. I'm saying because it's a congenital problem, so it is better to always to consider. And the thing is, now the deterioration is because of some arrhythmia, or it may be because of some lesion development, or a deterioration of an already existing lesion. So that's why I'm asking if it is in a volume overload, what are the possibilities?
Okay.
What is the conditions or congenital conditions of which can produce MR as a predominant one?
Congenital. Ma'am, MR. Ma'am,
The
firstly,
commonest is mitral valve prolapse with MR.
हाँ जी, mitral valve
Okay,
prolapse. हाँ
like
जी,
okay, like how the bicuspid valve is the commonest, in the
हाँ जी.
same way, mitral valve prolapse and MR.
MR.
Okay, then
Then, ma'am,
Parachute
dilated
myocarditis.
cardiomyopathy, and then
dilated
yeah,
cardiomyopathy.
myocarditis,
And
cardiomyopathy, and then MR.
MR.
Okay, then
Endocardial fibroelastosis. Have you heard about it?
Endocardial fibroblastosis.
fibroelastosis
हाँ
and
जी.
MR.
Alcapa.
Okay,
Alcapa is another cause
and
of
Alcapa.
Alcapa.
हाँ जी.
progressive
They'll
failure.
have the ischemia, failure, everything, and
Hmm.
palpitation also. That is the one thing. Okay.
Usually, mitral valve apparatus known to produce stenosis in a congenital, but is known to produce the regurgitations also. Okay,
Okay.
anyway, go ahead. Go ahead for the presentation.
Family and personal history. Patient has two elder sisters with no relevant history in siblings, no history of diabetes in mother. Patient is vegetarian by diet with normal appetite, bowel and bladder normal, sleep normal, LMP 15 days back, birth history born by normal vaginal delivery, which was uneventful, developmental history. Patient normal achieved normal milestones. Summary: 25 years female presented with progressive dyspnea from 6 years of age with recent worsening since 35 days along with on and off palpitations. Uh, Differential diagnosis as we have
Actually, your presentation, you said that class 1 symptom and no progression, deterioration only recently. So don't say progressive dyspnea,
okay.
static cardiac condition, and
Sure.
some precipitating event now for to precipitate the deteriorate the symptoms.
Okay.
Okay. Yeah, please go ahead.
Now coming to examination, general physical examination. Patient is conscious, oriented, time, place, person. Blood pressure 110 by 80 mmHg in right upper limb and 112 by 78 mmHg in left upper limb and 118 by 84 in right lower limb. Pulse rate 17.8 beats per minute, regular, good in volume, no radio radial, no radio femoral delay, no special character. Respiratory rate 19 per minute, saturation 98% on room air in all limbs, JVP not
Okay. Okay. With this, what do you think? First thing is it is acyanotic.
acyanotic heart disease.
Okay.
हाँ
And
जी,
then your pulse, blood pressure that you have mentioned
हाँ
rules
जी.
out the coarctation.
Practitioner of aorta
That is also ruled out.
ruled
And
out.
the third thing, the heart rate is 78. So tachybrady syndrome is unlikely. It is the
Unlikely,
normal.
normal.
Okay. And
हाँ
the
जी.
volume is good and no thing. Okay. Apart from that, it is not collapsing. Though like
Collapse.
volume is thing like aortic regurgitation or
हाँ जी.
MR, those things are
Ruled.
unlikely,
हाँ जी.
especially AR.
Okay.
Okay. And the JVP is not raised, that means it's not in the congestive failure. So
Congestive.
this much you can decide with this just general examination. Okay.
हाँ जी.
Okay, good.
Yes, madam said the analysis is very excellent. Just
हाँ.
to trouble you, I wanted to ask few more questions. Is it
Okay.
suppose there is no pressure difference in between the upper limb and lower limb? You will rule it out coarctation?
Ma'am, sometimes, ma'am, coarctation of aorta can occur with no pressure difference. Ma'am, I
No,
didn't.
even with the interruption of aorta, when the what to say, like the PDA is supplying the descending aorta, you may
Okay.
not find the difference, but
Difference. हाँ जी.
cyanosis will be there.
Cyanosis
Okay,
different. हाँ
yeah,
जी. Differential
cyanosis will be
cyanosis
there.
will be there.
Will be
हाँ
there.
जी.
Yes,
हाँ जी.
but that is not there.
That
So
is
we
not.
didn't think. Yeah.
हाँ जी.
This is only additional findings I wanted
Yes.
to mention about it. Otherwise, analysis should be like this only. And even
Okay.
extensive collaterals development, that also causes the equalization of the pressures.
Equalization.
Yeah, go ahead. Please go
Okay.
ahead. Sir,
JVP note.
Dr. Navdeep, you want to ask anything?
No, ma'am, it's fine. Please continue, ma'am.
Please.
JVP not raised. No pallor. No cyanosis. No clubbing. No pedal edema. Cardiovascular examination, inspection, chest symmetrical, trachea central, Precordium, no visible precordial pulsations, no scar, no sinus, no dilated veins. Palpation, apex beat is sixth intercostal space, just little to mid-clavicular line. Hyperdynamic in nature. No thrill, no parasternal heave, no palpable heart sounds. Percussion. Left heart border corresponds to apex. Right heart border is at right sternal border. Upper border of liver dullness that is in fifth intercostal space in midclavicular line. Left second intercostal space resonant.
I'm not,
Auscultation.
I'm not seeing the other students answering it at all. It is like a one-to-one interaction with the Puneet. Yeah, please go ahead.
I think that there are other PGs are there, they can ask her. Okay. Before we go to the cardiovascular examination, with this, what do you think? What is your analysis? Parasternal heave is not there. Pulsations in the second sound is not there. Okay.
Okay.
So, apical impulses?
Ma'am, down and outwards, it can be left ventricular
Cardiomegaly is there.
volume.
Yeah.
Left
Cardiomegaly is there.
cardiomegaly
Okay.
is there.
Is it LV type, RV type, or what it is?
Ma'am, it can be LV type because it is
No, you can't
downwards.
say it can be. It is LV type.
Okay, ma'am.
Okay. Because if you tell RV type, there has to be parasternal heave.
Hanji, ma'am.
So that is not there. So it is a LV type.
LV
Okay.
type.
Actually,
Is it?
One more
Is
point
it?
to add.
you
Okay.
describe LV and RV apex. That
Okay.
word should be very frequent to you. You can't say that it could be LV or RV. How the LV apex will be there, how the RV apex will be there.
Ma'am,
What is the classical description?
RV apex is ma'am, RV apex RV
Is
apex.
diffuse.
Hanji,
That is,
ma'am?
the word has to be used. RV apex is diffuse. It is
RV
not
apex is diffused
localized
with
like
medial
LV.
retraction, ma'am.
That is the second component.
RV will
You
have a
should use that
lateral
word diffuse.
retraction and the medial listing. So associated with the parasternal heave. Okay.
Associated with parasternal.
Okay.
The other
Whenever
thing
you
is that
ask the
RV,
distinction, you should start with the localized and versus diffuse.
Correct.
You are not using the word diffuse at all. So
Correct.
it is not there, so you can't say that it can be RV at all. In any description, it is not consistent with RV. Yeah, please.
one other thing to add is that our RV apex maybe sometimes better felt in the in the epigastric area. So if we are feeling good pulsation in the epigastric
Yeah.
area, it may be due to RV impulse.
Okay. What Navdeep is
You
telling
can
is, if you insert the finger in the epigastric region, that is a
Hanji.
subxiphoid region.
Hanji.
If you feel the pulsations, the RV hypertrophy is there.
RV.
Now, I'll ask you not for in this case, what is the condition where this RV impulse is totally absent? You put your index finger, you try to feel, but the RV impulse is not there. What is the condition? If you answer this, you are good in your congenital heart disease.
Ma'am, with respect to congenital heart disease, RV.
Anyone else? Any other postgraduate? You can raise the hand and unmute and answer. In the exam, they'll ask you this and you should know the answer. Okay, I'll give you the clue. Where the RV is either hypoplastic or not there.
Ma'am, just ma'am, hypoplastic.
I've given the diagnosis. I've
Hypoplastic
given
right
the...
heart.
No, but what is the condition? What happens when there is a
ST is the
tricuspid
normally
atresia? No. What happens in the tricuspid atresia?
tricuspid atresia, Hanji, ma'am.
Okay. When the tricuspid atresia, no blood is coming into RV. So as
RV.
Dr. Navdeep said, even if you feel in the epigastric region, you don't feel the impulse. That means the RV hypoplastic. Okay. Go ahead.
Auscultation in mitral area, soft S1 followed by grade 3 holosystolic blowing murmur. radiating to axilla in left lateral position at end expiration, well heard with diaphragm of stethoscope. In tricuspid area, normal S1 S2 heard. In aortic area, S2 normally split. In pulmonary area, low pitch blowing grade 2 continuous murmur with peaking in diastole with no radiation. A respiratory abdominal neurological examination are normal.
So before we go for anything else, let us analyze this. So P2 is normal?
Yes, ma'am.
Okay. And here, what you said is S1 and S2 are normal?
Yes,
That's
ma'am.
what you have written.
हाँ जी हाँ जी मैम.
Okay.
S1 S2.
If it is a pansystolic murmur of rheumatic etiology, what will happen to the S1 and S2?
Ma'am, in pansystolic murmur, S1 will become soft, and usually in pansystolic murmurs, S2 will not be heard in apical area, in the apex, ma'am.
Okay. But anyway, no, you said it is conducted to the axilla. So it could be MR murmur only, no?
हाँ जी मैम. MR.
But it is not a typical MR because you have written clearly S1, S2 are normal.
Ma'am, in mitral area, S2 not heard. Ma'am, in tricuspid area, S1 S2 normal.
Okay. Now, what does it your continuous murmur indicate in the pulmonary area?
Ma'am, in left.
Is it a PDA? Is it a collateral? Or is it hemodynamic wise? Or what is it?
Ma'am, in PDA, usually the murmur is continuous, but it peaks around
Not
S2.
usually. It is a
हाँ जी,
continuous
it is.
murmur. Classical continuous murmur is in PDA and AP window.
हाँ जी.
Okay. AP window, PDA both will have the continuous
Continuous
murmur.
murmur.
Okay.
Hmm.
What is the definition of continuous murmur?
Ma'am, continuous murmur starts after S1 and starts in systole and goes to diastole without an interruption in oncoming.
It is not
On,
interruption without change in the character. So
without changing.
whatever murmur you have in the systole, same thing is there. Whereas
In
in case of VST with AR, VST murmur is harsh, AR
and
murmur is same. So the character is different. So in
characteristic.
continuous murmur, it marches over the second sound without any
Any change
change
in
in the character. That is important. So here, what do you think?
Ma'am,
See, rupture of sinus of Valsalva, you can have continuous murmur. PDA, you can have AP window, continuous.
continuous murmur.
Then what is hemodynamic wise?
Ma'am, in ruptured sinus of Valsalva, it is an acute
No,
condition.
that is not a hemodynamic wise. I'm asking what is a hemodynamic wise giving rise to continuous murmur.
Ma'am, firstly, these are the murmurs from high pressure to low pressure areas.
Are Baba, I'm asking what is the hemodynamic wise?
Hemodynamic.
And where do you get it? In which condition? In a supracardiac type of TAPVC, the vertical vein will be between the left pulmonary artery and the left bronchus. So it is caught like like a scissors. It is caught between the two, and that's how you have obstruction and get the continuous murmur.
Continuous murmur.
So here we are not thinking of rupture of sinus of Valsalva. Why?
Ma'am, it is an acute condition. Further,
No. There is no collapsing pulse.
there is no collapsing pulse.
So there you rule out that. Okay, it is not hemodynamic wise because cyanosis is not there.
Sinus is not.
So PDA, it could be PDA, but usually PDA is a machinery type of murmur.
Machinery type of murmur.
So that word you have not mentioned. So we don't know. Then it is due to what?
It could be, ma'am, Al Kappa or coronary.
Now how can you go to Al Kappa? How will the Al Kappa cause the continuous murmur? Tell me how.
Ma'am, because of the collaterals from the RCA.
No, that's what I told you, no, either collaterals. So that the collaterals will have like this murmur only. So collaterals in general you can take, but collaterals invariably they are associated with either coarctation or with the cyanotic condition, like the tricuspid atresia. So we said tricuspid atresia is ruled out, coarctation is ruled out. So you are left with rupture of sinus or
Sinus
ruled out,
valve, हाँ,
ruled out.
ruled out,
PDA
ma'am.
is also ruled out because that will have again collapsing pulse or the
And
bounding pulse in the
okay.
peripheral, that is not there. So PDA, AP window, rupture of sinus of valsalva, and also hemodynamic wise, we have ruled out all. So you are left with collaterals in the
Yes.
acyanotic
Heard it.
condition.
हाँ जी.
So among them, which is the commonest?
Ma'am, first,
Alkapa.
हाँ जी मैम,
Okay.
अलका.
Okay, go ahead.
No, can you classify the murmurs of the continuous murmur causes? If you classify, you remember then all the causes, because the students are going and answering RSOV, pulmonary fistula, and many other things which we missed it. So, do you know the classification of the continuous murmurs?
Yes, ma'am.
Yes.
Condition number can be classified as firstly from high pressure to low pressure. Firstly PDA, Al-Kappa, RSOV, and then Lutembecker syndrome, mitral atresia with ASD, then coronary cameral fistula, uh, and secondly we can classify it according to these can be physiological also, like memory souffle, uh, venous hum, and AV fistulas. Thirdly, these can also be present anywhere where stenosis is there, like coarctation of aorta, pulmonary branch stenosis, and
Yeah. Now, fairly, you are able to cover everything. Now, you say which continuous murmur will have the diastolic in accentuation. That is one important clue you have it.
Ma'am, murmurs with collaterals have diastolic accentuation, like a coronary cameral fistula also has diastolic accentuation because flow
Puneet, one clue to you is the coronary flow is maximum during diastolic.
diastole.
So anything to do with the coronary will
Coronary
have the diastolic
diastolic
accentuation.
accentuation.
Okay, that is simple. Okay.
Anything else?
Anything. In AP window, ma'am, there is also diastolic accentuation.
Why? AP window almost equalizes. Unless it is a very tiny AP window, almost the equalization of the aortic and the pulmonary pressures. Actually, the continuous
There is
murmur
no
may not be
difference in
there at all.
AP window. AP window and PDA are the same.
Okay.
Okay, you cannot distinguish.
And AP window, if it is large, you may not able to hear in any murmur at all, because
Animal.
the equalization of both the pressures.
Equalization.
So that doesn't produce it.
Okay. Any other, Al-Kappa, coronary cameral fistula, ma'am.
RSOV rupturing into in a particular chamber.
हाँ जी मैम, there will be diastolic sensation. जी मैम.
Okay.
जी.
So this is because of the MR and continuous murmur. You are thinking because of the collateral. That's all your conclusion from your auscultation.
Yes, ma'am.
And what is the severity of the MR on the clinical examination?
Ma'am, since apex beat is downward and outwards, M are likely to be moderate to
So what
large.
are the D signs to say it is a severe MR?
Ma'am, firstly, LA enlargement, symptomatic MR.
We
Then,
have to
ma'am,
put an auscultation. So tell about the auscultatory findings.
auscultatory, ma'am, grade, ma'am, pansystolic murmur,
Okay.
With ma'am, with the narrowing of A2 and P2.
Narrowed A to P2. Okay. Narrowed, huh?
Yes, ma'am. Narrowing of S2.
Someone wrote as a wide split S2.
What? Ma'am, after
What will happen? Exactly, you say. You think about it.
okay, ma'am.
In MR, what will happen? The regurgitation is occurring during the systole. It is happening. And the diastole will have an excess blood. Next beat to go. So what will happen now? A2 occurs early or late?
Ma'am, P2 occurs early.
No, ma'am is asking about A2. A2. When will
A2.
A2 occur?
A2 occurs early.
Early, ma'am. Hanji, ma'am. There will be, hanji, ma'am, increase in the two.
So what will happen then? Because there's a regurgitation is occurring into the left atrium, less
Hanji.
blood goes from the LV to aorta. So
Hanji.
the aortic wall
A2
closes
will,
early.
hanji,
So you
early,
get
ma'am.
the A2
Hanji.
early.
Hanji, hanji.
So you should have a
In,
wide split or the narrow split.
ma'am,
P
wide split
more
in
will
VSG and
you
MR.
have a PH or something else.
Hanji, ma'am. In VSG, MR, ma'am, there is wide split.
So wide split. Sound
Hanji.
S1, wide split,
Hanji.
presence of S3. That is an important
Present, hanji,
finding
ma'am.
you have to mention, which you are not done it. And the murmur you said,
LVSG.
but many people doesn't consider the grade of the murmur is an important for the severity, and the presence of the mid-diastolic murmur, which is not there. So what is in points in favor for you to say that it is a severe MR? Except the murmur, nothing else is in favor.
Yes.
Hanji, ma'am.
Okay, you tell the clinical diagnosis. Next slide.
Provisional clinical diagnosis: cytosolitis levocardia, acyanotic congenital heart disease, likely PDA without Eisenmenger syndrome, or Al-Kappa with ischemic MR, decompensated heart failure, NVH class 3 without evidence of infective endocarditis.
And in sinus rhythm.
And in sinus rhythm.
Because you said pulse is regular and thing.
And one more thing.
Okay. Now,
Whenever
how will you, PDA, I will not accept it. Why?
Ma'am, because
Tell the points against the PDA.
ma'am, firstly, there is no collapsing pulse.
Collapsing pulse is not there. Okay.
Ma'am, saturation is normal in all
And the machinery murmur is not
and
there.
machinery murmur is not
And
there.
the thrill is not there.
Thrill is not there.
So PDA will have a thrill, it will have a machinery murmur, and it will have the
collapsing pulse.
collapsing pulse. So that is unlikely. So you should have put Al-Kappa first and PDA next. Okay. Now, how will you explain the continuous murmur and the MR murmur? You have written, but still I'm asking.
Ma'am, MR murmur will not go into diastole, while continuous murmur will go into diastole starting from the systole, ma'am.
No. You explain why the continuous murmur is, what is the cause mechanism, and why the MR. That's what I'm asking. Pathology.
Okay, ma'am. In Al-Kappa, continuous murmur is due to development of collaterals and due to ischemia in the LAD territory. There can be development of ischemic MR in Al-Kappa, ma'am.
Okay.
Or
I do agree with you because there was one girl, 11-year-old girl, treated as rheumatic fever with mitral regurgitation on penicillin prophylaxis. And then when she came, the pH was there, and I was baffled because there was a glistening endocardium. The glistening endocardium is never a feature of rheumatic fever. So then it turned, when you go to the short axis, there was the diagnosis. And so here, first you have to ask for the ECG. Which investigation you want first to prove your diagnosis?
ma'am, firstly ECG.
Yeah. Why do you ask for the ECG?
Ma'am, to see ischemia in LAD territory.
Ischemia can be seen in the ECG. Show us the ECG and show the ischemia. Okay.
One more thing, Puneet. please go back for the diagnosis.
Okay.
Never write the diagnosis like this.
Okay.
Cardiologist resident has to start the full description. Then he can talk about the differential diagnosis.
Okay,
Never
ma'am.
write the situs oritus, levocardia, and acyanotic congenital, then differential diagnosis. Even
Okay,
though
ma'am.
you are not able to come to a conclusion, you have to commit something. And
Okay,
then
ma'am.
only you can talk about the differential diagnosis. And all the components, whether the complications are associated, like a madam added is a sinus rhythm, all those things that has to be the mentioned about it.
Okay,
Yeah,
ma'am.
please go ahead.
ECG of the patient, ECG shows sinus rhythm with the rate around 80 beats per minute with the left axis deviation with poor progression of R wave. Ma'am,
Very significant, because
हाँ
the
जी,
LV forces are hardly there.
हाँ
The
जी,
poor progression is very, very obvious.
हाँ जी, मैम.
Okay. Any Q waves?
Ma'am, usually Q waves are present in L kappa in one and AVL, but ma'am, in this,
No, no. I'm asking, in this case, are the
mm,
Q waves present?
no, ma'am, Q waves are not there.
Is this
AVL,
consistent with
AVL
alpha or
there
no?
is, AVL there is, but not very sure.
No.
I'm not able to make out. Okay.
Is this is consistent with an alpha?
Okay.
And
Go to the X-ray then. Except that non-progression of LV, nothing else is there. Okay. Sinus rhythm. Then.
ma'am, this is the X-ray of the patient.
Mm.
It, ma'am, it is AP view
Mm.
with ma'am, pulmonary plethora.
AP view or PA view?
Ma'am, it is AP view, ma'am.
Why? Why AP view?
Um, ma'am,
Always you
because,
take the PA view, no?
yes, ma'am. Ma'am, it is
AP views are taken only in for the bedridden patients, those who are. Otherwise, it's always a PA view.
हाँ जी, sorry.
Okay. Why left and right are not written? Mark is not taken. Oh, you have cropped, is it?
Ma'am,
Okay.
it was
Okay. Okay, go ahead. Now describe the cardiac silhouette. Is there a cardiomegaly or not? Because apical impulse you said shifted downwards, laterally. There
um,
appears cardiomegaly.
ma'am, there is mild cardiomegaly
Okay.
and with mild enlargement of LA because there is obliteration of
No,
concavity,
how do you say LA? LA you don't say with the looking at that. You have to look at the carinal angle, no?
carinal angular double
If
density.
the carinal angle is widened, then you
Right.
say LA is dilated. Here we are not able to make out that. Okay. There is no plethora, there is no oligemia. So that much we can tell.
What is the major drawback of this X-ray, which you can't comment on the lung fields at all?
Okay.
Overexposed, no?
हाँ जी मैम, overexposed field.
And you are able to see in all the vertebrae. So how can you say that is
All the backside. And that's why he said AP view.
and that's why you suppose not to talk about the pulmonary vasculature. Okay.
Okay.
And look at the contour of the LV. It is almost convex, So
It
that
is
means it is LV is dilated.
elevated.
Okay. That contour is no, it is and it is dipping into the diaphragm. Apex
That,
is dipping in. Okay.
How is the left hilum? How is that?
ma'am, and left hilum.
Is the pulmonary artery dilatation is there or not?
Ma'am, no, ma'am, there is no pulmonary
Right side
dilation.
definitely it is not the dilated.
हाँ
But
जी.
how is the gap between the aortic knuckle and the left atrial appendage?
हाँ जी
What
मैम,
is it called?
मैम, it is gap is not there, ma'am.
No, it could be because of rotation also. You
हाँ जी
can
मैम
see the clavicles which are the completely rotated.
ओके
So that also you can't comment
ओके मैम
because at least on the right side, if it's dilated and it is very prominent, then you can say that yes, fullness on this side is because of the left pulmonary artery prominence. But now the problem is with this much of rotation, you can't be commenting on that also.
ओके मैम
So basically, you can say that is mild cardiomegaly. More than that, you are not able to say anything.
ओके
Okay, go ahead.
मैम echocardiography showed
Do you
mild
have a
dilated
recording of it?
मैम
Do you have a recording of echo?
हाँ जी मैम
Yeah, directly go for that.
ओके
You can read about it.
this is the parasternal long axis showing parasternal long axis showing
This
mild
is
to
a mild MR, you know.
mild MR.
Why did you say severe MR? And that's why Dr. Jyotsna was asking you. There are no features of severe MR.
मैम
Fluid MDM is not there. All those things are not there. This is just a
LVS3
mild
dot
MR. Okay.
mild.
Okay. Go to the next. No AR. Okay.
This is the apical four chamber view showing mild MR.
Hmm. No, you must have a color compare, you know, the both together side by side. Then you can see the glistening endocardium can be seen better. When with the color you show, no, we can't make out the endocardium.
Oh, जी.
When you have both color compare and with color, you know, you can make out the
Glis-
subendocardial ischemia better.
okay, ma'am.
Okay, show us the short axis now. Okay, here,
Ma'am, this view
plate,
shows,
plate, plate, plate.
ma'am, this is the only, ma'am, it is the image.
No, you can't make out the alcapa. See, for alcapa, say right coronary is seen and the
Ma'am,
left coronary is not seen there. And unless you
ma'am,
put the color and color compare, you cannot say alcapa. So, with this short axis, we can't make the diagnosis now, Puneet. See, it
okay.
is not a good short axis.
Ma'am, हाँ जी, ma'am.
Clearly you should be able to show the reverse flow. The alcapa should be shown in the color. Do the
Okay,
short axis, put the color and show the alcapa,
okay,
and
ma'am.
that has to be demonstrated. There should not be any artery coming from the left coronary sinus, and you'll have something across the pulmonary artery going, and that is alcapa. With this nobody can make out.
Okay, ma'am.
What is the next this thing? That is a video that is
Ma'am,
showing
these are the collaterals seen along the ma'am septum.
collaterals along the septum.
हाँ जी, ma'am.
No, but that is indirect. The direct one is you should be able to demonstrate the
It
alcapa
on the
in the short axis.
short
That
axis.
is important.
Okay, ma'am.
Okay, angiogram is done.
हाँ जी,
That's the
ma'am.
only echo findings you have it. So now you tell us why you wanted to suspect, in what conditions you wanted to suspect alcapa at all. Because you should know when to suspect, then you will search for it. Each and every case, you don't see the alcapa, na? You don't see for the alcapa. So what are the conditions which promotes, which make you to think that is, I have to see for alcapa?
Ma'am, overall all conditions, ma'am. Firstly, ma'am, in child, if the child presents with ma'am, LV dysfunction and chest pain or the anterior wall MI, then we can suspect L-kappa in that patient.
Okay. One is the with in a child it could be a cry only. Anginal pain won't be there. With
हाँ
heart
जी,
failure symptoms, with one and AVL V5 V6 having the
हाँ
Q
जी.
waves.
Q waves, then we can suspect L-kappa.
Echo wise, when you suspect it,
Ma'am, echo-wise, firstly, if there is only RCA originating from the aortic sinus.
Dilated RCA. First, it should be dilated.
Dilated RCA, and there is no.
And here it is dilated.
हाँ जी,
Indirectly, it is showing it is dilated.
हाँ
Yeah,
जी,
you can see that, it's quite dilated, right coronary artery.
That is the
But
main.
this is not a good frame. This is not a good frame to say Al-Kappa.
Okay, ma'am.
And very rarely you can directly demonstrate LCA taking origin from the pulmonary artery also.
No, always it is
Collaterals
demonstrated.
are
Short
draining,
axis, it is always seen.
collaterals draining, and then sometimes you can see the origin of the LM from the
left main
pulmonary
from
artery also.
pulmonary.
What is the first finding is dilated RCA.
Dilated RCA, ma'am.
Okay, go ahead.
Ma'am,
See here, you have not demonstrated the glistening endocardium. You have not demonstrated the Al-Kappa, and you have not demonstrated the absence of left coronary artery from the left coronary sinus. The three important things you have not demonstrated. That means the echo done is suboptimal, or maybe the frame that you have chosen is not correct.
हाँ जी,
Okay, go ahead. Anjo?
हाँ जी. This is the angiogram
Oh,
showing.
wow. Look at the dilated coronary, right coronary. Almost it looks like a AV fistula, no? Like that big it is. Yes.
Showing dilated and tortuous RCA draining into left, collaterals draining into left.
No. Show me again. In fact, you can go and see that it is. It will be supplying to the distal part of the left coronary also.
हाँ जी, ma'am.
Liver face.
And collaterals, ma'am, drain into pulmonary artery, ma'am.
Okay, you have to do the aortic root to show that there is no left coronary artery, and then do the selective angiogram from the pulmonary artery.
Okay, ma'am.
So here you have done right coronary artery. Okay, yes, there it is. You show that. Now freeze. Okay, freeze. Now you see that left coronary sinus is blunt. Nothing is coming from there. Okay. This is a indirect evidence that there is an Al-Kappa. The direct evidence is go into the pulmonary artery, do the selective angio. So that is good. The aortic root indicates that there is, because right coronary artery can be dilated even in coronary AV fistula.
Okay,
But to say it is Al-Kappa, there should not be any vessel coming out from the left coronary sinus. That is nicely seen there. Okay.
And one more thing is you should take a prolonged angioviews. One thing is dilated RCA, you will say, and then retrograde filling of the left, and this left system draining into the pulmonary artery, and opacification of the pulmonary artery. All these things you can demonstrate if you take a prolonged video recording.
Yes, that's correct.
Ma'am,
where is the selective angio?
Ma'am, these are the two views.
No, but surgeon should know, no? Otherwise, they'll have to search where is the origin. You must know where that is. So enter the pulmonary artery and hook. First do the general and then hook that coronary and inject.
Okay.
Now you finished the angiogram. Can you demonstrate still by any other means?
Ma'am, by angiography.
Angiography,
like CT, she is asking whether you want to do this.
Ma'am, we can demonstrate the origin by cardiac CT.
CT was done in this patient, madam. But unfortunately, we are not having the images for this patient.
Okay.
CT has been done.
Navdeep, is this your patient?
Yes, ma'am, she's my patient.
The technician has done the echo?
Actually, ma'am, the echo was done by the technician during the
The
routine
one thing,
workflow.
start doing yourself,
No, no, Dr.
because
Puneet actually
because the
shared.
technicians won't know what to look for,
Yes, ma'am.
but you will
I
know what to
apologize
look
for
for.
that,
Yeah, yeah.
but I being the single faculty, so I was not able to do this
Okay.
echo. And meanwhile,
No,
the
no,
patient did not
no,
came for
no,
follow up.
no. Especially when you're presenting
Yes, ma'am.
from
Yes.
your department, it is coming. You should do it.
No, actually, ma'am,
I actually
Whatever
suggested
the
these
that
burden is,
to
I
responsibilities,
used to
yes,
do
ma'am.
myself. All important cases, I used to do myself.
Yes, ma'am, I do
It's
agree
very
with you.
important because we understand the anatomy better than the technicians. They
So
won't know.
Navdeep
They
had shared
randomly
his
will do that.
apprehension when he said that we are going to present
Yes,
this
ma'am,
case. He
definitely,
shared
I
the
do agree with
apprehension, ma'am, I don't have a good echo. He was on leave.
I know,
He's
I
still
know,
on
no,
leave
no, no, no,
and
it's
not going.
okay. No, but
I
that is
said, but you
also
still
learning,
present. Yeah.
We are learning from that also. Do's and don'ts we learn from this.
The
Yeah.
Okay.
direct evidence is absent, then only we see for the indirect component.
Indirect.
We learn more.
Yeah.
So nothing
Okay.
wrong in that. Anyway, you have the
Correct.
CT. So what was done to the patient finally?
Ma'am, finally, patient, firstly, the patient was managed with diuretics, and then patient was advised for surgery and further follow-up at
No, no,
PGI.
no. You advised all right. Is the surgery done or not? That's what
Nee,
she's
ma'am,
asking.
till now, the
Ma'am,
ma'am
actually,
surgery is not done.
we had a meeting with our CTVS
Okay.
colleagues also, and the
Okay.
surgery has been planned but not yet
Okay.
done.
Okay. 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 Now, why I'm asking is we had a medical student. He came with a VT, and that turned out to be, these patients can go into LV failure and we may lose them. And that's why, in the newborn babies also we do the surgery because they come with the failure. And she has survived till 24 years. So most of the children of Al Kappa, they present within 2 to 3 months of birth.
Mm.
And the rare conditions, like I told you, a medical student
Why
at
they
the age of
presented in
22,
3 months?
and another girl at 11 years as a rheumatic fever. So these are all rare conditions. So here also, the clue that we got was the palpitation, which was coming on and off. So she
Mm.
must be having ventricular tachycardia at that time, though it is not seen in the ECG. And
Mm.
that should give you the clue.
We had ventricle
With
ectopics on the ECG. We had some
then
ectopics,
in
VPCs.
3 months.
Puneet, you have done fairly well, and you are like a S master. Haji, 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 you are telling. So you are an S master. So when I heard you saying Haji, I remembered one of the examiners. I can tell the name also. One Dorai Raj, he used to come as examiner, and I used to be the chairman. So when the candidate is going wrong, he would go on encouraging them and praising them. And anyone who would say Haji, Haji, Haji to him, that fellow will fail. So you should know that. See, straightforward examiners you have, and nobody has pulled your legs. But people can do that also. So you should be sure of your findings.
Okay, ma'am. I will, ma'am,
No, I'm just
improve.
telling in a lighter way. Don't worry. You have done well. Okay,
Yeah.
good.
So
So, any questions in the chat box, Shibba?
there were some questions, but we have simultaneously answered. There was a query by someone in the question answer regarding a single ventricle, but I think that has already been ruled out by you, and most
Yeah.
of the answers have been covered. I think it has been an amazing day, and let me tell you, Puneet, I mean, oh, there's somebody just now who's asked, ma'am, any role of cardiac MRI?
Ma'am, cardiac CT, um, role of ma'am, cardiac CT as equal as cardiac MRI.
No, as on today, the
We
angiogram
can
is a
look.
gold standard.
And
In this case, you have not done the selective and the surgeon doesn't have the proper roadmap, and then you can go for the cardiac
cardiac
MRI.
MRI.
Because precisely where it is the origin, they can know. Because that has to be brought and stitched back to the left coronary sinus, no? So that distance is very important for them. So that's very important. Okay.
Yeah, so I think Puneet, it has been a great day, and hats off to you. To get this opportunity, I think to present in front of Masteros as Dr. Vijayalakshmi Madam and Dr. Jyotsna Madhury, and you should actually be thankful to your mentor and guide who was so keen that you come present and come forward, and it's really been a great learning session for all of us. Also, learning so many points and revising. We would have some comments from Dr. Navdeep, and then Soumya, please conclude the session thereafter.
And it has been a very enriching experience. I would like to thank all the team of WINCARS and especially Shibba ma'am and also our esteemed examiners Vijayalakshmi ma'am and Jyotsna madam. I too had the opportunity of learning and revising many of the points from them, and it's always it's very
Oh,
enlightening to interact
you
with
are being
Vijayalakshmi
very,
madam.
very
And
humble and
even
nice.
Dr. Tara also.
You are a gentleman.
Thank you, ma'am, once again.
Okay. Okay.
Thank you,
Doc-
ma'am. Thank you, teachers.
Dr. Soumya, are you there? I think.
I think she's not there, ma'am.
I think maybe some technical issue. I can see
You
Dr.
can
Majella
conclude,
there.
ma'am.
So, Dr. Majella, kindly conclude the session of the day.
Yeah,
My abundant
Cecily,
thanks
how
to
are
you.
you?
Fine, ma'am. Good evening, ma'am. How are
Yeah,
you,
good,
ma'am?
good,
It was a
great,
great session. I
great,
joined
great.
a little late, ma'am.
Good, good, good,
Extremely
good.
sorry, ma'am. I got
No,
held
no,
up in
no,
an
no problem.
emergency. Yes, ma'am. On behalf of the WINCAS, I would like to thank our IB Vijayalakshmi ma'am, Dr. Jyotsna ma'am, and the presenter who has Dr. Puneet, who has taken keen interest in this session. We live to learn and learn to live. We will continue, keep on learning. And I thank one and all for this great opportunity, and Dr. Shibba ma'am, Dr. Pavani ma'am, and Dr. Sowmya, all who have been coordinating for this every month, who has taken so much pain and efforts, keep the vibe going on.
Big clap to
Thank
all
one
of
and all, and
you.
all the
Yeah,
participants and students who are here, who have
yes,
participated in this session.
Yeah,
Thank you.
that's
Thank you so
true.
much, ma'am.
Thank you,
Thank you,
Majella.
ma'am.
And of course, thanks to Dr. Navdeep, who was, volunteered within a minute and was ready, and
I
because
know.
of
He
which we
should be
learned so
thanked
much.
first.
Yeah,
He
Yes,
thank
should
ma'am.
be
you.
Yes,
thanked
ma'am.
first,
Dr.
for
Navdeep sir.
getting the
Sorry,
class.
sir.
Yeah.
Extremely sorry. I couldn't. Please.
No, ma'am, please
And
don't be. Please don't be.
and
It's
of
my pleasure.
course,
Sorry,
yeah.
sir. Extremely
And of
sorry.
course, Medgemi for this wonderful e-class and the platform that they give us.
Sure,
And of
sir.
course,
Sure.
all the students who have joined and interacted. It's all for you. Thank you, one and all, once again. A big bye-bye.